This is Group 1 for Public Health 805. Our policy proposal is mandated monthly counseling for reducing burnout in resident physicians. So, just a quick background, physician burnout is an epidemic in the US healthcare system, with nearly two-thirds of physicians reporting signs of burnout. Burnout is a state of emotional, physical, and mental exhaustion caused by excessive and prolonged stress. While many factors contribute to burnout, this healthcare epidemic is often associated with system inefficiencies, administrative burden, and increased regulations and technological requirements. As doctors in training, residents are particularly vulnerable subsets of physicians, since the burden of learning how to become an independent doctor is already extremely difficult. Trying to navigate the business and social aspects of medicine compounds the burden, thus making the burnout even likely. Residency burnout has led to an increase in suicidal ideations, actions, and medical errors. Employment vacancies add upwards of 4.6 billion in costs to the US healthcare systems annually. To give a little bit more analysis for social, political, and ethical, Graham has.
When we analyze the social aspects of residency burnout, resident physicians experience higher burnout rates than other professions due to grueling work hours, demanding responsibilities, and sleep deprivation. The resulting burnout leads to depression, family issues, and professional impairment, thus affecting the quality of care provided to patients. Politically, the Accreditation for Graduate Medical Education, also known as the ACGME, is the main body responsible for accrediting residency programs and setting guidelines for residency programs to follow. Thus, the fate of stakeholders such as patients, hospitals, hospital staff, residency programs, and residents lie in the hands of the ACGME. Ethically, the issue of residency burnout must be addressed to ensure patient safety and quality of care. Moreover, the health and lives of both physicians and patients must be safeguarded.
Burnout is an issue not only affecting 50% of US medical residents, but also around 28 to 45% of medical students. The current policy in place to target resident burnout is that of the ACGME 2003 reform, which is aimed mostly at reducing work hours. Minimal revisions have been made to these guidelines over the years to enforce rest periods between working hours. It also emphasizes the importance of giving residents the opportunity to attend medical, mental health, and dental care appointments, and stresses the importance of educating residents about burnout. One advantage of the current policy is somewhat mitigating resident burnout by reducing work hours. However, due to individual variability, focusing mainly on work hours will unfortunately not benefit all residents. One of the major disadvantages of this policy is that these regulations primarily focus on the residency training period and do not follow residents past their training. We need to change this policy because physician suicide rates are as high as 400 residents annually, which is higher than any other profession. It is also important to note that burned out doctors are more likely to make medical errors resulting in compromised patient care compared to their healthier peer counterparts. The high levels of stress associated with burnout can impair decision-making, result in anxiety, depression, and substance use or abuse. Also, physician dropout negatively impacts the economy due to the cost of lost hours, hiring, and training to fill vacant positions. It was determined that the economic cost is approximately $7,600 per physician per year.
As you can see, resident burnout is mentally and financially taxing. An effective policy must be introduced to ensure the mental health and well-being of residents. Hence, our policy proposes 1 hour mandated monthly individual counseling sessions for all resident physicians in the US. Now, you may be wondering whether 1 hour monthly sessions are effective. While the literature states that higher frequency sessions on a weekly rather than monthly basis are preferred, most studies are focused on individual rather than organization-wide based therapy, as is our case. Due to the mandated nature of our policy and an effort to not drain resources, we believe monthly sessions are more practical and will slowly initiate residents into the therapy process. If more resources are needed, additional sessions outside of the work hours and telehealth visits will be made available. In regards to the effectiveness of psychotherapy itself, it's been found that 50% of clients had reliable improvement with just 8 to 10 sessions, which correlates to around 8 to 10 months in our policy, leading to lasting improvement. The ways in which our policy will improve upon the status quo include the following: reducing work hours by 1 hour per month so as to not affect the quality of training, mandated counseling for all residents will allow those with mental health issues to receive care free of stigma. Sessions will be incorporated into the workday itself, making it convenient. Individual sessions will allow for an air of confidentiality and flexible scheduling, contrary to group sessions. Mental health will be treated proactively rather than reactively to avoid the consequences of severe and costly mental health crises. And finally, a diverse group of counselors will be vetted by the administration to ensure as best fit as possible for our residents.
To focus on budgeting, specific costs for implementing such a policy was not cited in the literature. As mentioned before, economic burden of burnout is still almost $4.6 billion. It is assumed that economic burden for resident programs would be supplemented through medical insurances provided by these programs and would help alleviate some of the financial costs. Assuming that each program has about 30 residents and occupy a coverage of $35 for each 1 hour session, this would also accumulate a cost of $12,600. Next slide. So our resources and services were broken down into 4 categories. The human resources, ACGME, would be focused on implementing policy. Program directors would be involved in managing and directing, as well as monitoring and evaluating the programs, and as well as also procurement of mental health care professionals through the use of the hospital's HR department. Financial resources includes basically resident programs insurance, and this policy uses systems that already exist, including health insurance and residency program administration.
The following are specific actions recommended in order to initiate the proposed policy. The ACGME will finalize the policy and distribute the relevant information to residency programs. Next, the residency program directors will identify several appropriate mental health care providers, ensuring that they accept the resident's insurance, that they are easily accessible to the resident, and that they are not people that the residents would encounter during their workday. Then the policy will be presented to the residents, and the chief residents will incorporate this monthly session into each resident's schedule. It's important to note that this hour will be taken out of the residents' work time and not their free time. Then we have events that are occurring every 6 months. This will firstly include residents providing anonymous feedback online, including any questions, comments, or suggestions they have for the ACGME to improve this policy. Secondly, the residents will complete the Maslach Burnout Inventory, or MBI, which includes a variety of questions on emotional exhaustion, personal accomplishment, and depersonalization to evaluate burnout. Thirdly, program directors will submit their compliance reports, which indicate that each resident has completed their 6 monthly sessions. And finally, the ACGME will use all of this data to determine the policy's efficacy and to make improvements on it.
We recognize there may be some limitations to our strategy, and this includes 1 hour monthly interaction with mental health professionals may not be enough to address all the concerns of a resident. Some residents who believe therapy won't benefit them may not take it seriously. Certain issues might not be discussable or solvable with a counselor. The additional job requirement of counseling may add to the overall stress of the residents. Since there is no direct involvement of the program leaders in the residents' mental health concerns, addressing the problems may not be possible. Although a good first step, the 1 hour intervention will require assessment and modification to best suit the needs of the resident. Not all residents will be a good match with their therapists, which might create a limitation to how much benefit they achieve from their session. In conclusion, our proposal aims to target burnout-induced physician dysfunction and suicide. Previous ACGME guidelines to reduce burnouts were ineffective. Our intervention is geared towards improving resident mental health and eventually improve the well-being of their patients. Some of the requirements of our intervention includes mandatory counseling using pre-existing resources. Surveys, compliance reports, and MBI results will be used as quality metrics. Monthly professional counseling sessions are recommended. Thank you.